Welcome to the first of 5 lecture videos on newborn stabilization. The nursery nurse or the labor nurse that is going to initially take care of the newborn must make sure that the supplies are at the ready and in working order. Things we bring are warm towels and blankets, numerous of them. Eventually, you need a thermometer and a stethoscope. The stethoscope is usually hanging from the warmer. Check the drawers and make sure that you have an extra bulb syringe and suction catheters available. The suction catheters will hook to wall suction that's available on the warmer. In general, the obstetrician will hand you the bulb syringe when the baby is moved over to the warmer. You need to have a scale in the room. At Mission Hospital, you have to physically bring it in to wherever you are because there's only one shared by all the labor rooms. In facilities that have the Panda warmer, the scale is built right into the warmer. You'll need a tape measure to do head circumference, chest circumference, and the length of the baby. Eventually, you need the medications for the newborn. Some facilities have them in a cabinet located in labor and delivery, while others need to be secured from the Pyxis system. You need to document your findings on a baby chart. Now remember, this is a brand new life. They are not admitted to the hospital until the nurse calls admitting and says, "We have a newborn, here's the name," etc. So in the interim, you need to document all of your assessment findings, the weight, the length, the APGAR scores, your initial vital signs, and you're going to continue documenting this on a paper-based chart until the electronic medical record is available, and then all this information will be transferred. Know where the emergency equipment is located within the department, and some facilities have a dedicated baby crash cart. In addition to making sure that your equipment is ready, you need to review the prenatal record. Are there any red flags? What are you on alert for? Well, some examples are, is this woman Rh negative? Was she a diabetic? Is this baby preterm, post-term? What was her GBS status? All of these have implications for the baby at birth. How has the labor progressed? Has it been precipitous? She came in and she went from 1 to 10 in 30 minutes? Or has she been in labor for 36 hours and pushing for 2 hours? It's going to be a whole different scenario for resuscitating this newborn. Was this patient induced? And if so, why? When were the membranes ruptured? Were they artificial or was it spontaneous? What color was the fluid at rupture and what color is the fluid now? Has the mother been given any medications? And if so, when and what was given? If she had IV Nubane 15 minutes ago and now feels the urge to push, you may have a depressed newborn on your hands. Did she recently have an epidural and afterwards had the hypotensive episode where the baby has started having decelerations also? And now she says, "Oh my gosh, the baby's coming." You may need to do some form of stimulation for this baby. So let's look at the pictures on this slide. Just take a moment. Are you worried about any of them? If you are worried, why? So I'm going to start with the baby on the top right. Am I worried about this baby? Just a little. The reason I'm not 100% worried is this baby's crying. So I know his heart rate most likely is over 100. His lungs are working. I do look at his color, and automatically on the APGAR score, he gets a 0. because he is blue head to toe. What is of concern to me is that his arms look like there's not much in the way of muscle tone. And then I look at his feet, and you can see that he is automatically Babinskiing himself. So neurologically, this baby's intact, but for some reason, there isn't a lot of muscle tone on the upper extremities. So we need to investigate that. The baby on the bottom right is looking pretty good. He's got a cry because he's got that facial grimace. Doesn't look like a vigorous cry. He does have some vernix, looks like a decent size, but when you look at that head, look, it's misshapen. So this baby has been stuck in the pelvis for a while. When I look at that umbilical cord, I know I have some work to do because that's far too long to leave it as is. So I'm going to end up clamping it much closer to the abdomen and cutting it. Now looking at the baby on the left, are you worried about this kid? He looks like he's got great muscle tone, good posture. He's a little bit blue, his head's blue, his feet are blue, but the extremities look pretty decent. So I might knock off 2 for color on his APGAR, or I might knock off 1. But what is concerning is when you really look closely at the fluid on this baby's skin, it's greenish, which means that this baby passed meconium in utero. So at some point, he had a neurologic insult to the point that the anal sphincter relaxed and the baby passed its first stool inside. We can't tell exactly when this happened or for how long it's been going on. When the baby comes out, being in meconium fluid, we worry about meconium aspiration. So this baby needs to be suctioned carefully right at birth. So back to the interventions before and at delivery. So once again, make sure your equipment is all ready and turn the warmer on a good 5 to 10 minutes before this baby is expected to deliver, and it will penetrate through all of the towels. Assess for the ABCDs, airway, breathing, circulation, and any obvious disabilities the baby may have. So having a misshapen head isn't a disability, but if it has extra digits or it has a myelomeningocele, etc., that's a disability. We do an APGAR score at 1 in 5 minutes. We take the baby's temperature. You need to dry the baby, and we do it with a bunch of towels or blankets, and be fairly vigorous because that also stimulates the baby to cry. Replace any wet blankets with dry ones and then place a hat on the baby. The weight, length, head circumference, and chest circumference can be done at this time, or it can be done later because we want this baby to go skin to skin with the mother. If the cord is too long, you can apply a cord clamp. So these photos show you a different, these photos demonstrate where the cord clamp should go. So the one on the left, to me, that's a little bit too long. I would go much closer to this stump coming out of the abdomen. And then we're going to cut it. I like to also cut it enough so that people coming after me can actually see that there are 3 vessels to the cord. That's an assessment that you need to make when you are cutting this cord. Once all of this is done, you need to hold and then carry the baby to the mother or father. Now these babies are slippery and they wiggle, so make sure that you have a firm grasp where your hand, where your pinky finger is at the shoulder level, your palm of your hand is behind the baby's neck, and then your thumb and forefinger are holding the base of the baby's skull. Then in your other hand, you want to support the sacrum and then take your thumb and forefinger and wrap it around the thighs. You'll have a very good grip on this baby and then hand it over to the mother. So this ends part 1.